Hello, let's talk about Graves' disease and other causes of hyperthyroidism. Thyrotoxicosis means you got too much T4 in the blood. Hyperthyroidism refers to overproduction of T4 by the thyroid gland. So just because you have thyrotoxicosis doesn't mean you have hyperthyroidism, but if you have hyperthyroidism, you do have thyrotoxicosis. And excess T4 in the blood could be caused by a primarily hyperthyroid state, thyroiditis being a common cause, or it could be due to exogenous thyroid hormone administration. Some people take thyroid hormone to lose weight. There are other medical conditions you would take T4 for. And finally, a few drugs, amiodarone particularly, contains a high percentage of iodine by weight, and so that iodine goes immediately into thyroid hormone synthesis. Graves' disease is the most common cause of thyrotoxicosis. In Graves' disease, real easy diagnosis, exophthalmos, hyperthyroid symptoms, high T4, low TSH. You might also see a toxic multinodular goiter, which is going to be a goiter that's essentially making T4 and unresponsive to TSH feedback stimulation. So it doesn't matter how much or how little TSH you have, this goiter is cranking out active thyroid hormone. A toxic follicular adenoma of the thyroid, same thing going on there with that word toxic. What that means is that even though there's low TSH, this follicular adenoma is making T4 autonomously. So it doesn't need TSH to make T4. And then thyroiditis, we covered in our SDL talk about Hashimoto thyroiditis. Thyroiditis means that you get some transient inflammation of the thyroid. And so as soon as that inflammation starts, follicular thyroid cells will just release all of their T4 because they have some that's preformed and stored up. They'll put it into the bloodstream. And then as the itis, the inflammation continues, then those cells will burn out and lose their functionality. And so with the thyroiditis, you get an initial hyperthyroidism followed by a lasting, sometimes permanent hypothyroid state. Then there are a handful of lower yield TSH secreting hyperthyroid pathologies that we'll talk about at the end of this SDL. Hyperthyroidism has a prevalence of roughly 1% of the population, tends to affect mid-aged to older adults. What does hyperthyroidism look like? Well, thyrotoxicosis, that's too much T4 in the blood. So remember, all hyperthyroidism is going to be thyrotoxicosis. And when you have too much T4, you see symptoms of a hypermetabolic state. Your body's really, really active. And when T4 binds target tissues, it induces metabolism, the use of energy. And so symptoms of hyperthyroidism are going to be things like a fast heartbeat and a high cardiac output, nervous system hyperactivity and hyperreflexivity, and also cutaneous flushing and sweating. And many of these symptoms can be explained by thyroid hormone's weak adrenergic activity, because thyroid hormone is synthesized from tyrosine, and that amino acid is always also used to produce catecholamines like epinephrine and norepinephrine. And so thyroid hormone has some adrenergic activities that are going to work on the heart, for example, at beta-1 adrenergic receptors to increase contractility and heart rate, and then also on alpha-1 receptors to induce vasoconstriction. So once you understand that, the symptoms of hyper versus hypothyroidism make a lot of intuitive sense. In the heart, patients get tachycardia, sometimes palpitations, a flutter, a fib, and we treat these symptoms usually with beta blockers, and beta blockers are incidentally the first line treatment for hypothyroidism, and especially for managing it on an outpatient basis because of thyroid hormones' similarity to epinephrine. In the nervous system, insomnia is commonly present, nervousness and emotional lability as well, and then hyperkinesia, that is another way of saying brisk reflexes. Patients do complain of muscle weakness and easy fatigability, and that's just because the muscles are using so much energy that there's not much left over for contraction, I would assume. Also, weight loss is a big systemic effect of having too much thyroid hormone or thyrotoxicosis, and thyroid hormone might be taken exogenously as an attempt to lose weight. Thyroid hormone really affects the eyes. And this is where you're going to see many of the first symptoms that direct you towards hyperthyroidism rather than you just having a vague idea of what it is. When you see it in the eyes, it's going to cause eyelid retraction. That's the big take home. And that leads to a lot of symptoms of dry eye and a lot of complications downstream from that, things like corneal scratching and degeneration. And the eyelid retraction is also accompanied by this symptom called exophthalmos, which is like the popping out of the eyes from the orbit. And that's going to be due to the accumulation of glycosaminoglycans, especially in Graves' disease, due to the activation of the thyroid stimulating hormone receptor by autoantibodies against that receptor. And thyroid stimulating hormone is expressed on the surface of fibroblasts, and when it binds, it's going to get those fibroblasts activated. It's going to metabolically activate them. So what's the job of fibroblasts? Well, synthesize extracellular matrix and hold everything together. So that ECM comes in the form of glycosaminoglycans, namely hyaluronic acid, glucuronic acid, and those GAGs get into the extracellular space and they attract water because they have a lot of alcohols and protein groups on them, and water will just invest in between the branches of these glycosaminoglycan trees, and you'll see some edema in the tissues that are collecting these glycosaminoglycans after the fibroblasts have been stimulated by autoantibodies against TSH. Now, thyroid hormone also affects skin and hair. If you don't have enough thyroid hormone, then your hair is going to start falling out. If you do have too much thyroid hormone, you're going to be sweating and you're going to be vasodilated. In the GI system, if you don't have enough thyroid hormone, you're going to have hypomotility, so constipation. But if you've got too much of it, your bowel's just going to be cranking because it makes you metabolically active. And so frequent bowel movements that yield normal stools. Diarrhea is rare, but you are going to have a lot of bowel movement. Osteoporosis might be seen in hyperthyroidism. It's going to induce metabolic activity. And in the bones, what does metabolic activity look like? Remodeling. And finally, loss of a period, oligomenorrhea, amenorrhea, and possibly anovulation frequently occur in thyrotoxicosis because your TSH is going to be low, and TRH does play a role in stimulating the production of, so TRH is made in the hypothalamus and TRH goes to the pituitary. The pituitary makes TSH, but TRH is a general signal of need from the hypothalamus. So when TRH upregulates TSH, it will also minutely upregulate the production of GnRH, gonadotropin-releasing hormone, which makes FSH and LH, and those are two things you need for proper reproductive health. And so if you don't have enough TRH, because T4, well, when you have hyperthyroidism, you have a lot of T4 in the blood, so that would feedback inhibit TRH and thus put a little bit of a damper on GnRH and thus FSH and LH. So any hyperthyroidism is going to have a high T4, and most of them are going to have a low TSH. And if TSH is high and patients got a high T4, you know that they've probably got a TSH-oma in their pituitary gland. Graves' disease. Quickly, it's a type 2 hypersensitivity, technically, because you've got autoantibodies against a cell surface receptor, and that receptor is the thyroid stimulating hormone receptor. So some antibodies in Graves will activate the TSH receptor and some will nullify its activity, and then others are just plain neutral. So that's kind of peripheral. What you really want to understand is that you're going to see high T4. You're going to see a low TSH secondary to that. Here's the TSH receptor. It's a G protein. It's got 7 cyclical transmembrane units and a stimulatory alpha subunit that will activate adenylate cyclase and get your cyclic AMP going up inside a cell, which is going to promote activity. Now, Graves is an autoimmunity against this TSH receptor. You understand that anytime you have an autoimmunity, there's a breach of self-tolerance that we normally maintain pretty efficiently. So one would think that you're exposed to some sort of antigen, maybe a molecular mimicry type scenario, that's going to look very similar to the TSH receptor or a part of it. And so exposure to that exogenous antigen can generate an immune response that is non-specific enough to include the thyroid stimulating hormone receptor in its scope. And then after you clear that initial infection, well, now you're left with a bunch of antibodies that are shaped similarly enough to TSHR to be able to bind it. And there's your breach in autoimmunity. And so that'll just keep on going because you've got a lot of TSH receptor in your body. So your immune system is always seeing that antigen and mounting an immune response against it. So cyclic AMP, the TSH receptor, when bound, is going to raise cyclic AMP, and that's really important for getting the ball rolling on the process of thyroid hormone production, because that is a pretty metabolically expensive process, and you need a strong activation signal in order to initiate it. You've got to do things such as pump iodine in through the basolateral membrane of a follicular cell and then out the apical membrane into the colloid of the thyroid follicle. You also have to upregulate the synthesis of thyroglobulin, which is the precursor protein to active T4. Then you have to iodinate that protein using the thyroid peroxidase enzyme, and that is all happening in the follicle of the thyroid, which is similar, analogous to the lumen of the kidney. And that follicle is filled with colloid, and that colloid is where all the enzymatic magic happens. And then you make active T4 and it gets pumped back into follicular thyroid cells and then out into the bloodstream. So TSH receptor is not only found at the thyroid, it's also found on the cell surface of fibroblasts and adipocytes and white blood cells, as well as osteoblasts. So that fact accounts for the multisystemic manifestations that you're going to see in a hyper or hypothyroidism. But particularly here with Graves, you've got the antibodies against the TSH receptor. And we're talking about this TSH receptor that's on fibroblasts, fat cells, and bone cells. So in Graves, you have antibodies that bind to this receptor and usually activate this G protein cyclic AMP cascade. Now, some Graves antibodies, some variants of Graves, there are different phenotypes for this genotype, understand that. Some antibodies are going to be antagonistic and they're going to stop the effect of TSH. And then some are going to be totally neutral and they're not really going to push the TSH signaling cascade one way or another, but they will still attract immune cells to this receptor that is bound to the neutral antibody. So the vast majority, 90 to 100% of cases of Graves' disease are going to have thyroid stimulating hormone receptor antibodies with stimulating activity. And that's this right here. That's the leftmost graphic in this trifoil panel. Antibodies will bind to the receptor and get it working. So once you understand that, then you just need to understand what the receptor does and everything makes sense. Let's take a look. Here is the thyroid stimulating hormone receptor on the surface of a fibroblast, and we're going to say that this is an orbital fibroblast in the socket of the eye. Now, this antibody here, recall we're saying it has a stimulatory effect. So when it binds the receptor, even though it's not the proper ligand, this antibody isn't TSH, but it's going to affect the same purpose as TSH would. So it'll bind and raise cyclic AMP, and it will also activate the mTOR pathway to get this fibroblast cranking. I mean, really doing what it ought to be doing. And what ought a fibroblast be doing? Throwing down extracellular matrix. So that happens, and then water follows this extracellular matrix, and so water edema pours into the orbital socket. And TSH receptor is also on the surface of adipocytes, and you've got some fat cells in your eye. You've got a lot of extraocular fat that serves to cushion that eyeball there. And so it's going to get these adipocytes proliferating and dividing. And so that's going to increase the fatty content, the adiposity of the orbital socket. And so those things combined are going to make your eyes bug out like this. And like this. So really nothing that the patient can do about it. It's not a voluntary control type of thing. You know, you can't just say, hey, squint a little bit more, you know? I mean, dude can't because his eyes are like, so. And you also see in this picture, eyelid retraction. When we said eyelid retraction, this is exactly what that looks like. That upper lid is like back, you know? And so you couldn't close your eyes even if you wanted to, you know, because that the muscle that raises up your eyelid is getting fibrosed by all the inflammation that comes along with this autoimmunity. And so that muscle, as it gets more fibrotic, it's tougher to pull. And so it shortens up a little bit, you know, because that's what a muscle does when it can't expand or contract. It's going to go to the contracted state. And so that muscle that raises the eyelid gets stuck up. And this opens the door for, again, corneal pathologies and xerophthalmos. Quick look at a glycosaminoglycan. You know what that looks like. Here's thyroid myxedema, and it's staining blue with this special stain that picks up collagen. And I want to remind you, this is the same sort of pathology that's going on in a mitral valve prolapse with myxomatous degeneration. A tissue is acquiring a lot of these glycosaminoglycans within it. It's swelling up in size and in weight, and that can give you deleterious consequences depending on where it is. So that is the result of this autoimmunity against the TSH receptor. You might also see TSH receptor antibodies in Hashimoto's thyroiditis. And in the setting of Hashimoto's, they would be blocking antibodies. And so they would be, as we see here in the middle of this trifoil panel, preventing the TSH receptor from working properly. So this right here in the middle is Hashimoto's. And then that makes a lot of sense to us because Hashimoto's thyroiditis is going to give you ultimately a hypothyroidism. So if the TSH receptor can't work, you're not going to make thyroid hormone. And in Hashimoto, TSH in the blood is going to be up, but then T4 is going to be down, which is the opposite of Graves', in which TSH is going to be down, but T4 is going to be up. Now, Graves' might also show you antibodies against thyroglobulin. You might see anti-sodium iodide symport antibodies. That's going to be a SLC gene name. And there's much overlap in the pathology of thyroid autoimmunities, but most TPO antibodies tend to be from Graves', just like most anti-thyroglobulin antibodies tend to be found in Hashimoto's patients. And for your purposes, getting told the antibody in the question stem is the cherry on top because TSH and T4 are really going to make the diagnosis for you. Then the SDL talks about intrathyroidal T cells. The majority of the immune response in Graves' disease is mediated by CD4 Th2 helper T cells, which are then going to activate B cells to generate more and more and more antibodies against the receptor. Germinal centers in the thyroid are much less common than they are in Hashimoto thyroiditis. Remember, the B cell containing follicular germinal center was a hallmark of Hashimoto thyroiditis. So we'll take a look at some histology and compare Graves' to Hashimoto. Epidemiology now. The HLA-DR3 genotype, that's human leukocyte antigen, which is the same thing as major histocompatibility complex. And this is HLA-D. So would that be a major histocompatibility complex 1 or 2? That would be 2. Remember that HLA-1 is going to be A, B, and C, and then MHC2 is going to be HLA-DR, DQ, D something, that good stuff. It's been suggested that Graves' is associated with an antecedent infection, but not proven. Graves does tend to ramp up in severity following emotional stress. So separation from a loved one is quite stressful. Acute frights, automobile accidents can be frightening. More common in women than men, as in Hashimoto's. Pregnancy is a time of immunosuppression, so the disease tends to improve with pregnancy. Shout out amiodarone, which is 37% iodine by weight. Why would we give amiodarone? Rhythm control and cardioversion. Atrial fibrillation. And also, contrast agents. When you order that contrast CT, many of them contain iodine. So that's something as well to be acutely aware of. Now, smoking is associated with a big risk of Graves' disease. And if they give you a bunch of risk factors and smoking is the only one on there that lines up, I'd say pick that. Now, how does it get rolling? There's a break in tolerance. You know that your body typically tolerates its own proteins, which means that it sees them, but it doesn't mount an immune response against them. So something's going to happen to get your body popping off against its own cells. There's going to be an antigen presenting cell, whether it's a macrophage or a dendritic cell or something, that will recognize thyroid stimulating hormone receptor. And that APC will show it on that MHC2 HLA-DR3. It'll show it to a CD4 T cell, and that T cell takes it and sends out a cytokine signal. Specifically, IL-4 is going to get B cells involved. Hepatitis C has been very closely linked to Graves' disease. I know we said we really have no evidence for this, but we have observed a correlation wherein patients that get Graves' disease tend to have a history of Hep C virus. And interferon alpha is going to be one of those cytokines produced by Th2 cells that will get the ball rolling on amplifying that autoimmunity. Molecular mimicry has also been reported between Yersinia intercolitica and the thyroid stimulating hormone receptor. So tell me what you know about Yersinia. Well, it's a gram-negative. Enterocolitica means it's going to cause an upset stomach most of the time. Potentially can be a cause of lymphadenitis, mesenteric lymphadenitis, and that'll look a whole lot like what other pathology? Appendicitis. So Yersinia is transmitted often through dairy products and milk, and also through dog feces, and also can spread through daycares. Gram-negative, Rod. So how does hyperthyroidism or thyrotoxicosis affect the thyroid gland? Well, it's going to be diffusely enlarged in most patients, and that's going to set it apart from something like a thyroid cancer or nodule. But some patients with Graves' disease will have a totally normally sized thyroid. So this is not what's making your diagnosis for you. I do want to point out that if you ever get a question stem that says you palpate or auscultate the thyroid and you feel or hear a thrill or possibly hear an audible bruit, what they're getting at is that's hyperthyroidism, not hypothyroidism. Because hyperthyroidism, you're getting a lot of blood flow to the organ versus hypo, in which the organ's just kind of atrophying and dying. Moving further in the symptoms, thyroid ophthalmopathy, that's the name that we give to the eyes bugging out, can get pretty bad. Upper eyelid retraction is what you want to understand. And it's our levator palpebrae superior muscle that is going to fibrose and contract. Says this right here in the SDL. Upper eyelid retraction is a result of fibrotic contracture of the levator palpebrae superior. So this fibrosis is mediated by the autoimmunity against the TSH receptor, which is an extremely high concentration in the orbit due to the fibroblasts and adipose there. Another cause of lid retraction is humorally induced overactivation of the superior tarsal muscle, which is right behind the levator palpebrae superior muscle. And so both these working together, yeah, your eyelid just goes, it goes straight up. And so when we say humorally induced sympathetic overstimulation, well, that's because thyroid hormone has some slight adrenergic activity. And so this superior tarsal muscle particularly is sensitive to the adrenergic effects of thyroid hormone because it's smooth muscle, not skeletal muscle. So if the patient has lid lag sign, that means that their eyelids are stuck up. If you see that they have exophthalmos, that means their eyes are bugging out. And again, it's because fibroblasts are going to divide and differentiate into adipocytes and also produce excess glycosaminoglycans in response to this autoantibody binding thyroid stimulating hormone receptor and activating it, similarly to how normal TSH would. Extraocular muscles swell due to the glycosaminoglycans, and you might see optic symptoms of diplopia, double vision, or strabismus when one eye's here and the other eye's like going like that or like that, like that. Think about a cranial nerve palsy, that's strabismus. And because your eyelids are stuck up, they get pretty dry. You could get corneal scratches and ulcerations. You might be more prone to a conjunctival infection. Thyroid dermopathy has the exact same mechanism as thyroid ophthalmopathy. It's stimulation of that TSH receptor that gets fibroblasts producing glycosaminoglycans, which pool up inside the dermis and just attract water. And so skin swells, and we call that myxedema. And if you don't see it in the face, a common peripheral location is pretibially, so on the front of the legs. And as compared to normal peripheral edema, which makes its way into intracellular space by means of either a really high hydrostatic pressure or a really low plasma oncotic pressure, this edema is associated with a lot of erythema, redness, because thyroid hormone, active thyroid hormone, is going to really, again, ramp up metabolism and cause cutaneous flushing. So that's something that you don't necessarily see in every example of normal edema, but you do see almost every time in myxedema. Thyroid acropachy is an extreme manifestation of Graves' disease with digital clubbing and swelling of fingers and toes, involving a periosteal reaction in which bone growth is promoted. So the bones grow, then the tissues over the bones grow, and then you got these big old fingernails. Pathology of Graves' disease. Diffusely enlarged, typically might be a normal size. It's pink. It's not overly fibrotic. There's no cancers on it. So that's what you can tell just by looking at the gross biopsy. Histologically, the two hallmarks are going to be follicular vacuolization and scalloping. Let me rephrase that. Scalloping, when they say scalloping here, they mean follicular vacuolization. And then you also see thyroid follicular hyperplasia around the lumens of the thyroid, which contain colloid. So the follicular hyperplasia is just a bunch of columnar cells right next to each other, kind of proliferating in a palisading manner. And when we say palisading, it looks like a bunch of dominoes stacked up next to one another. So if you see this and they're protruding, bumping into the colloid, that's follicular hyperplasia. You should definitely suspect a hyperactive thyroid pathology. You know, this is not going to be any thyroid atrophy here. This is an excess of thyroid growth. That means you got a lot of TSH. But in the case of Graves', you don't have a high TSH. You have a lot of TSH receptor antibodies that are working the same exact way as TSH works, in that they're going to stimulate thyroid hormone production. But because these receptor antibodies are activating and causing you to make thyroid hormone, that T4 feedback inhibits TSH, which is why you would see a low blood TSH in these patients. Back to the histology, the most characteristic finding is going to be the vacuolization of colloid. So here you can see it's just bubbles. It's just plain white soap bubbles around the edge of the follicular colloid. And notice that you don't see any bubbles at all in this normal picture in the upper left here. So those bubbles are basically pathognomonic for Graves'. And what's important to note is that Graves' disease does feature diffuse thyroid changes. If you see it in one part of the thyroid, you will likely see it in all parts of the thyroid, versus something like a papillary carcinoma, which would show you focal histologic and gross changes in a section of the thyroid. So lab studies, we said T4 is up. Why? Because of TSH receptor antibodies that activate cells. And when they work on the thyroid, you make more thyroid hormone. And then TSH itself in the blood will be low. Why? Because T4 feedback inhibits TSH. Now, you can do a radioactive iodine uptake test. And if you were to do that on a Graves' disease patient, what you would see is that the thyroid is enlarged and it's taking up a ton of iodine. It's going to be a denser signal than a normal thyroid. And so what that means is that TSH receptor antibodies, which have a stimulating effect, are telling thyroid cells make thyroid hormone. And so you draw upon blood iodine in order to do so. Now, if the patient has thyrotoxicosis, meaning they have high blood T4, but they hit you with this radioactive iodine uptake scan, that's going to tell you that they're probably getting iodine from an exogenous source, and it's getting converted by a normal thyroid into too much T4. Not that there's any hyperplasia of the thyroid itself. So a low uptake in association with thyrotoxicosis signals the presence of thyroiditis. Well, what's going on there? Inflammation of the thyroid gland, meaning that you transiently release all the T4 that you have on store, but then after you've used all that T4, you start going down, then you get hypothyroidism because your gland's atrophying because of inflammation. Low uptake of iodine in association with thyrotoxicosis could be due to factitious thyrotoxicosis. That just means patient is taking exogenous thyroid hormone. And most common cause of that is going to be, I'm trying to lose some weight. Thyroid hormone is going to ramp up my metabolism. That's going to just melt my fat. What else could give you a normal uptake scan with the thyrotoxicosis? Well, iodinated contrast. Patient's got a lot of iodine, so the thyroid is using it, but there's nothing necessarily wrong primarily with the thyroid itself. And finally, amiodarone, keep going back to that because it is 40% iodine by weight. Same thing there as with iodinated contrast. So that's Graves' disease, the autoimmunity. What else can give you thyrotoxicosis? We just mentioned a couple causes. The toxic multinodular goiter. So we will talk about a goiter in the next SDL or the one after it. And a goiter just means your thyroid is big and swollen. And goiters are typically due to hypothyroidism, in which patients' iodine intake is low. But you might see this toxic goiter, and what toxic means is that your thyroid is just making thyroid hormone without waiting for TSH to tell it what to do. It's uncoupled from TSH. And so another word we might use for that is autonomous. And toxic goiter typically arises out of a long-standing multinodular goiter. So you're hypothyroidotic, but then all of a sudden some follicular cell gets pissed off and decides to start making T4 all on its own, and it divides and its children follow suit, and now you've got a toxic goiter. That's my understanding of what's happening there. In a toxic goiter, you don't see thyroid ophthalmopathy, but you do see high blood T4, which lets you know thyrotoxicosis. Toxic follicular adenoma, same concept with the word toxic. That means that this adenoma is not waiting around for TSH to tell it, hey, make some thyroid hormone. It's just sitting there making thyroid hormone all day long. And it's going to be an adenoma, which is a benign cancer of glandular tissue. It's going to be a follicular adenoma, specifically because those follicular cells are the functional cells of the thyroid that are handling that thyroid hormone as it goes into the colloid and then back out into the blood. So if a patient's got a thyroid adenoma, you will be able to suppress their thyroid stimulating hormone because, again, it's uncoupled from TSH. And that would be a hot nodule on a iodine uptake scan, and I'll show you what we mean in a minute there. A thyrotrophic pituitary adenoma is just going to be making TSH all day long. So if you're making TSH, you're making T4. So if you had a high TSH and a high T4, let me tell you, this is the only thing that would ever give you a high TSH and a high T4. Nothing else is going to have both columns elevated like a pituitary adenoma would. You could have a metastatic follicular thyroid carcinoma that could set up shop elsewhere, maybe in bone, you know, and maybe in the lungs, and then it would end up producing T4 there. You could have gestational hyperthyroidism, which obviously presents in a pregnant patient. It'll show up as severe nausea and vomiting with weight loss as well. The nausea and vomiting, that's that gastric hypomotilic state, that weight loss, that's just the influence of hypermetabolism. So hyperemesis gravidarum is our name for that combination of symptoms along with high T4. And it's because human chorionic gonadotropin, which is a pregnancy marker produced by the implanted embryo, that's going to cross-react. It's got some slight tropism for the TSH receptor. It'll stimulate that receptor and cause increased T4. Trophoblastic hyperthyroidism. So we just said human chorionic gonadotropin has some tropism for the TSH receptor. Well, trophoblasts are producing a ton of HCG all the time. And what are trophoblasts? Well, they're those things that connect the blastula to the wall of the uterus and then to the placenta. And you've got cytotrophoblasts and syncytiotrophoblasts, remember that. So this is not exactly particular to women because men can also develop these things called choriocarcinomas, which are going to arise in the genitalia and then produce hyperthyroidism by virtue of the fact that they're secreting human chorionic gonadotropin. And then finally, we've got this struma ovary, which is whenever you have an ovarian tumor that's secreting ectopic thyroid hormone. Remember, ectopic is the same thing as perineoplastic. So if you've got this perineoplastic thyroid hormone production, what would your TSH be? Really low. And what would your T4 be? Obviously up. So then you take a radioactive iodine scan and it's totally normal at the thyroid because it's not a thyroid problem. It's an ovarian tumor. Finally, factitious thyrotoxicosis. Patients taking T4 for some medicinal reason. Maybe it's in order to suppress TSH in patients with particular cancers. Maybe it's for weight loss. Maybe it's for depression. A lot of, I don't know, means and methods which patients resort to when primary treatments don't work. So remember that if you give a patient iodine, their uptake scan is going to be net, null, nothing on that iodine scan when they have this exogenous thyroid supplementation. So let me see if I got anything in my slides extra. Let's take a look at the histology of Graves versus Hashimoto's. This is Graves, and how do we know it's Graves? Because we're seeing these bubbles all over the thyroid. Let's see if green is the blue might be the choice. Look at these bubbles in the thyroid. So that's vacuolated cytoplasm. And you don't see that at all in Hashimoto's. So this patient will have a low TSH and a high T4. Now, here's Hashimoto thyroiditis, which you understand is also an autoimmunity, but you just see a ton of lymphocytes in this, John, and very, very small, extremely small follicles, barely any lumen, barely any colloid, just lymphocytes all over the place. You'd see a high TSH in this patient and a low T4. This is a hypothyroidism. Here's Graves. Check out that vacuolization. It is clear as day. Big time vacuolization in this follicle. You still do see a lot of follicles. There's a decent lymphoid aggregation here, but you're certainly not seeing any germinal centers, which is characteristic of Hashimoto thyroiditis. Here's Hashimoto's. Man, look at this large island of lymphocytes here in the upper left quadrant of this picture. And you're also starting to see some fibrosity, and that gland's going to atrophy as it burns out. This is a thyroiditis, and we know that fibrosis is kind of the body's attempt at healing wounds, and inflammation is an abstract wound. And so you see lots of fibrosis in the end stages of Hashimoto thyroiditis, and that's an atrophied, non-functional thyroid gland. It's a hypothyroidism. Here's your Graves. Here is a normal thyroid on the left. You don't see no bubbles, but then here in the midst of these different follicles, we're seeing peripheral vacuolization of the colloid. Again, big hallmark for Graves. Notice also that it's hypercellular because there's an inflammatory response going on. And finally, one more look at Hashimoto thyroiditis. If you zoom out low power enough, or if you catch it at the right spot, you're going to see these germinal centers all over the place. And those are B cells in the middle with T cells, those darker spots around the periphery. So very easy differential. They look totally different histologically. They look totally different on labs.